care, and also to study immunological changes in health and disease with aging. And this is sort of this far out kind of Star Trek-y type vision that I'm sort of engaging with, is that if we can prevent people from getting sepsis and other methods that we can, other approaches that we can use to try and understand the community-based epigenetic interactions that lead people to having these abnormal responses to pathogens, that we might be able to correct in the community to try and prevent sepsis before it gets to the ICU. So next slide, please. So in summary of the work that I've shown you, we have described two phenotypes of sepsis, the hyper and hypoinflammatory, in about 15,000 patients. 30% are hyper. The hyper has higher pro-inflammatory cytokines, endothelial dysfunction, lower protein C, increased organ failure in the hyperinflammatory phenotype, increased bacteremia with Enterobacter ACI, and that appeared to respond differentially to a multitude of therapies, including PEEP strategy, fluid strategy, activated protein C, potentially polymyxin B, and simvastatin. So with that, next slide, please. I will just leave a slide of acknowledgements of so many different collaborators, and this is just the tip of the iceberg. And so many people have been so generous with lending their trial data and observational cohorts for us to carry out our investigations. And I'm obviously grateful to the NIH for all the funding they provided for this research. I'm happy to take questions.
Thank you so much, Dr. Sinha. Dr. Kouchoulis, I think we have one question, and then we'll, oh, we have a question in the audience. Dr. Lial?
Oh, thanks. Great presentation. I just have a quick question on the classification of the phenotypes. Is that based on a single time point, for example, at ICU admission? And what about the trajectory of sepsis? Would there be change in the phenotype, or it's a static assessment?
That is such a great question. This is a huge limitation of the work that we've shown you, that I've shown you, is that we have studied it at cross-sectional time points. And these phenotypes are highly dynamic. And we have some emerging data. Initially, we had put a paper out that showed that they were quite stable over the first 48 hours, but I think that's a misinterpretation of our data. We have a paper that's currently under review where across about 5,000 patients, we have shown that these are highly unstable, and how quickly the hyperinflammatory phenotype resolves is highly predictive. And one of the most important predictive features of these phenotypes is how quickly you go from hyper to not being hyper in terms of your prognosis. So if you go from hyper to hypo in the first 48 hours, your outcome is almost the same as being hypo at the start. So the longer you spend in the hyperinflammatory state, the worse your outcome is. So I think we have to be very mindful when we're interpreting this data and doing real-time phenotyping. How do we consume this information about the temporal dynamics of the phenotype?
Thank you.
Fantastic. We're going to keep moving and circle back to some of these questions in our time together later. It's my pleasure to introduce Dr. Bihorik, Senior Associate Dean for Research at the University of Florida. And she's going to speak on AI for the future of sepsis management. Take it away.
Well, thank you so much, Vinny. Can you hear me?
Yep. Yes, we can.
It's great to be the last speaker talking about the future. It's a really great day. I learned so much. Excited to be together with like-minded researchers, scientists. So let's move on. Next slide, please. I apologize that I did not put my disclosures. I do not have any conflict except my funding from NIH. So I want to think it's about framework of how we think right now, that our prediction model, our mental model around sepsis goes from, can we anticipate or predict risk for sepsis, and then how we diagnose it as soon as possible, and then moving to the treatment. Next slide. So in that kind of framework, I want to rethink of each of these steps in terms of what AI can bring in terms of enriching our approach to sepsis patients. So I firmly believe in prevention. I think that the prediction, if we focus on two major types of sepsis, community acquired, and in my opinion is a very important subtype of sepsis, and hospital acquired that we have focused mostly for now because we have mostly data in the hospital, we need to start thinking about how data can be generated in both setting towards true prediction of even of infection and organ dysfunction towards fully blown sepsis. And then moving to diagnosis, how can AI help us get more precise, more biologically accurate diagnosis, as our previous speaker really eloquently put forward. I think we are desperately needing more treatments and recovery enhancing strategies that are at this time really limited, and eventually monitoring, whether monitoring of the patients can help us longitudinally predict not only to have what happens today, but what happens 3 months later or 6 or 1 year afterwards. As we all know that sepsis does not end at the hospital discharge. And then that's kind of longitudinality of approach. Then we have a scaling. You know, we need to go from N=1 from individual patient and scale really our approach from healthcare institutions to learning health systems, state, nation, and maybe global ability to see what's happening on a global scale with sepsis. Let's move on. Next slide, please. So I was just going to review a couple of things that many of you have mentioned. We already have the first FDA-approved model for sepsis prediction in hospital, Immunoscore, with 22 parameters, biomarker from EHR. Next slide. Among many studies here is the AI model that aids sepsis prediction in hospital. It was deployed in quasi-experimental clinical study and showed some reduction in mortality in the pre and post implementation analysis using deep learning model and really with some explainability and projecting actually who might develop sepsis. Next one. But what about community-acquired sepsis? Well, I want to argue that for us, in the first step, in a prediction stage, we need to focus on getting more dense data and different type of data than we actually acquire during routine clinical care. So here is some use of the wearable biosensors at home, even before you come to hospital, whether you will be able to actually capture your symptoms before you even develop full-blown either infection or sepsis. This is some data from the use of wearables in a neurodegenerative disease or Alzheimer's. You're looking at a motility pattern. Next slide. Another big disease would be congenital heart disease. Again, you have an entire spectrum of different biosensors. Right now, mainly focused on our physiological parameters, but a lot of untapped potential for that, both in hospital and I think especially outside of the hospital. Next slide. And what is most exciting for me, we are approaching the era of completely different next generation sensors that can now watch many more things, from gastrointestinal tract metabolites to sweat sensing platforms for chemical analysis to even mobile bioadhesive ultrasound that can give us actual imaging in the real time. So I think that's another very exciting area that we will see a lot of movement. Next slide. And I think what I call it is for me what I call multidimensional biohacking. So I think in our current approach, we are lacking dimensions, both in a scale and in how wide they are. Here is an exciting study from the NASA twin study of two identical twin brothers. Probably many of you have read this study in Science in 2019. Like a multi-scale profiling of two brothers who one's staying on the earth, one's going into space, and then not only it's a multi-scale, but it's a longitudinal on many time points, highly dense data, showed some really exciting changes that are happening on very granular level in the humans once they launch to space. Next slide. So this multidimensional biohacking now have another dimension, N=1. I think the next 10 years will be all about N=1ism, going from the central place of a hospital, of the place where we gather, more to the homes, to individual patient where we can track ourselves. These are all my sensors that I have, tracking myself, and you are having now even more commercially available algorithms that will just tell you that when you are not feeling well. And I don't think we are not far away from the moment when we will be able actually to really signal to our patients at which time they need antibiotics and which time point they maybe need to go to hospital, because they are at the risk of progression towards this very vague term of the dysfunctional immune response. And I think adding to these physiological, mainly physiological signals monitoring, we're going to have entire spectrum of new chemical or even imaging sensors applied to N=1. So next slide. And that really brings me to this, whether we can do something like that even in hospital, where we are very much limited now on a structured clinical data. This is a study using a little bit of non-structured in the text, but entire spectrum of imaging is yet not plugged in any of the models that we are using. And even more importantly, more biological data. Next slide, please. So that would be, like how do you encompass and move towards multimodality, but then you need to vertically integrate all of that. I think in a community setting, we will move with this multidimensional biohacking to vertical connection with the providers, either through the telehealth or through the digital twins of hospital or your practices or some subscription system, that you will actually be able to act on what you are sensing or deciding as N=1 individual patient. And I think we're going to see decentralization, perhaps even of those who take care of these patients before they come to hospital, so they never come to hospital. I would say the compression of morbidity is probably the best approach we have now, meaning as long as the best approach to staying healthy is to never get sick. So next slide, please. And a little bit more moving towards what we are working, what we call real-time ambient intelligence, more to the hospital setting. Besides data generated through the clinical care, can we use other sensors and collect different type of data that may more emulate human perception? As an example, none of our models use any visual cues. As a physicians, we enter the patient room, we use vision, smell, hearing to really make decisions about what's happening to our patients. So we have used sensors such as RGB and thermal cameras, some of the depth camera, and so on, to develop this series of deep learning algorithms that track certain characteristics of the patient in real time. Here is our end-to-end platform to track mobility in the room without any human input, so you can actually 24/7 monitor patient in the rooms, and really use that data to predict, as example, mobility pattern, activity pattern. And I will show on the next slide, these are now moving not only from our mobility, but also to the facial expression. One of our approaches to use, next slide, please, is to use end-to-end action unit detection of the face with a vision transformer. So you can actually decompose human space in 48 action units. These action units then combined create our emotions. So combination of some action unit equals certain emotions. So in our approach, we are now actually able to autonomously capture the patient's face in a room full of other humans, and then track that face in real time and assess the activity of certain action unit and then correlate them with the clinical severity. Next slide. And here's a very small, here is a place where we use our clinical model trained on the structured clinical data, and then use transfer learning in our smaller cohort of visual cues. We call these visual cues. Each of action unit was inputted in the clinical model, and there was significant improvement in the ability to predict the severity of illness when you incorporate these visual cues in a regular clinical model that is based on structured clinical data. Just kind of putting that back at the bedside, how many times you enter patient room and you just take a look at patient and you say you don't look good. And I think that is something that we are going to be able to incorporate in our practice more and more, not only through the visual, but also acoustic tools, patient voices, also environmental cues. Environmental telemetry will become a big part of this decision-making. Next slide, please. That brings me back to digital twin, the idea that we can actually use this densely multi-scale sample longitudinal data to create some twinning of the existing individual patient that can mimic biological processes. Unfortunately, for the true biological twin, we need to have a deeper understanding of first principle of many complex processes in a sepsis. There are some agent-based modeling groups that are working really hard on that. I think we are far away from this. And for me, this is one of the biggest, really the biggest missing point, where we need to combine these biological mechanistic model with our clinical models and really move towards this true digital twinning. Next slide. Next, AI in a treatment and recovery. I think we desperately need new treatments. Hopefully digital twins and more deeper multi-scale modeling can help us find new targets and test them in the new therapy. Again, this is somewhere in the future. Next slide, please. Level, and hopefully we will have more than just the salty water and good air to deliver to our patients for treatment of sepsis. Next slide. Again, similar, another study that looked at use of reinforcement learning to optimize corticosteroids therapy. Again, similar approach, and I think we're going to see more and more, especially even combining endotypes. Some of these endotypes were able to classify patients who might be steroid responsive, and this is now using computational approaches that can automatically map patients' phenotypes to optimize therapy, perhaps taking human factor out of the loop once we are confident with this system. Next. So the future of AI for sepsis in one slide, I would say it's a full stack of approach from prevention to diagnosis, treatment, recovery, monitoring, and then back to prevention. I think it needs to happen throughout to, not only in a hospital, we need to get out of the hospital, at home, in any setting. So using much more than a currently collected clinical data, expanding use of pervasive sensing, ambient intelligence, and developing and merging a lot of insight we have on animal models and more biological work that was done in a sepsis, merging that with our clinical understanding of the disease and putting all these dots together to create like fully holistic, fully explainable model, dynamic, mechanistic model of sepsis that is translatable to clinical practice. And I hope that we will see less sepsis, that eventually we will be out of the business as intensivists, because all sepsis will never be sepsis. It will be just infection and immune system that we will take care of. So that's my vision for the future. We will be out of the business, hopefully. Thank you, Rini.
Wonderful. What a great blue sky for us in the future, that we are going to be out of jobs, which would be great. All right. Well, I think we're going to take this time to bring together all the presenters so that we can have some discussion and address some questions. Great. So while we do that, I see there's a couple questions in the chat. And we can get to those. Maybe I'll turn it over to Dr. Katroulas to kick us off.
Yes, thank you, Vinny. So this was very interesting. All the sessions were really amazing and very insightful. One question from the last session is about the differences at baseline and in response to treatment, and how digital twin, the digital twin would take that into account. Like, people have different baseline comorbidities or problems, and they don't move the same way, or they don't, they're very different. How is that accounted into the model?
Vinny, you want me to take it?
Yeah, sure.
Yeah.
Why don't you start?
Yeah,
I
well,
think everybody has
I
some
can
thoughts,
give you
but
my
yeah.
vision. That is, so like I think that we need to get out of our mentality that only things that we know what to do with we're going to collect, because that's not going to take us where we want to go. The data need to be so dense. So I envision deeply that if you think about true twinning, when you start getting born, you're going to be completely sampled. Like this is, I'm going to omic or image myself continuously until we have enough data with that type of density that we can start asking these questions and create a replica. Because, I can make a sketch of myself with 3 black lines of like a black pencil, but then I can do beautiful colors, right? So we want to come in the most beautiful painting of me rather than just kind of rough sketch of my little child. We are not there. We don't have that type of data. We have not enough data on healthy subjects. What is worrisome for me is that we will see with a technology, digital divide might be even bigger, because people will have a capacity or ability to gain that intensity of data might not be every person, even in this country. So this is going to be expensive divergence in what is accessible for everyone, or maybe for what's accessible only for a few. That's just my view.
Great, thank you so much.
Anyone else want to try, add some thoughts to that? I guess I'll just add a comment, which is what struck me from this conversation was that we're talking on many different resolutions and scales. Some of the stuff that Pratik has gotten into is trying to unpack the biological processes, and then Kara is speaking at the the human layer of intervention that is really like socio-technical, not biologic, and then and then I think, Andre, you've addressed some of the translation. What are we capturing and how do we leverage those EHR data, which is a proxy of some treatments, some, biologic processes, whatever. Then Azra, you're talking, like instrumenting the entire thing, both temporally and with extensive multimodal capture, which like we don't even have depth in one vertical today, I would say, And so that vision, and part of that challenge is, how do we turn the dial on the resolution, both with respect to any one of those multimodal aspects, but also with respect to the trajectory of illness, both in the pre-sepsis phase and then through kind of like that transition. So I wonder if anyone has thoughts on, what do we tackle, what do we tackle strategically as we move forward?
But I'm gonna step in, but mostly rambling through my very biased perspectives. But yeah, I don't know. I've been practicing intensivist now for like 20 years. I don't know what sepsis means, and I think that's a fundamental problem that we need to get around. And it's not even that complicated. We can break it down through a number of tangible, potentially in clinically intuitive ways, but we just have to, at the outset, help broader populations to be captured in subsegments. And I've been fortunate enough to work in the ED and in the ICU, and they are fundamentally very different spaces. Even just breaking it down through those domains will provide us a little bit of validity and homogeneity, which we can then study. I noticed that Kara is a hospitalist, and her take of sepsis is probably much earlier and has very different outcomes and interests than what I'm now just practicing just as an intensivist sees. So I think that is a fundamental problem that we need to try and get over. And at the same time, I think there has never been a better time to be alive, to be a sepsis researcher, because we do, I agree with what Azra said, that, we haven't collected the data that we need to, but we're definitely further along on that journey. And there are these multimodal data that I have access to, which like 15 years ago, I couldn't even dream of. And I think that is where the opportunity lies, and where we can start breaking them down into pathogen and host response interactions that are meaningful and potentially treatment responsive, and turning sepsis into a disease rather than what it is right now.
I think I'll step in also. But to add to that, I think one of the reasons why it's a great time to be a sepsis researcher is because not only do we have access to the computational resources to capture and analyze a lot of this data, but there's also, we also have the ear of a lot of investment, both financial and time-wise, in capturing a lot of the kind of data that we would need to help identify exactly what sepsis is, to Pratik's point, and also how we can better understand what may happen before it's clinically recognizable, and also break down those different types of sepsis once it's identified to capture the heterogeneity in treatment. So I think that's one thing. And I think there's also some examples in current practice and also in certain institutions that are trying to capture more of that data indiscriminately, so that perhaps we can then use it later on to analyze and to help answer some of these questions. One example that I would use is the UC system, right? So they currently have, and speaking as a person who's not worked there and speaking to someone who basically knows secondhand about this, but my understanding is that they have the capability to capture a lot of that data and have investment to try to store it and analyze it for the purposes that we're discussing. So I think, using that as an example, if there are other institutions that implement similar processes and essentially are capturing data that we don't really know what to do yet with, I think that's going to help push the needle and move the research along to where we're envisioning it.
Great discussion. I don't see anybody with questions.
So I'm
I just want to
wondering,
make a comment, if I may, like going
Sure.
from future to current. I think what, I feel our biggest responsibility as physician scientists is to avoid shortcuts, to really don't allow shortcuts, because there are no shortcuts here. The shortcuts, like just deploying something that is inadequate, that is, limited, is not going to help anyone. And I think I'm very worried about that with the hype, that if you worked in ICU long enough and you work with the data science long enough, you absolutely know that the shortcuts are dangerous. And for me, that is critical, that actually we need to step up as a physician and become a guardrail of safety of this technology that will penetrate everything. And we need to educate our physician, because eventually there is only one person who is liable, and that's physician. So no matter what technology says, you will be signing your liability. So I think that's, for me, really important and kind of captures my imagination in a daily basis.
Yeah, I agree. Such a good point. And I'd also throw in a plug for the need for, and again, I'm talking myself out of a job here, but the need for a diversity of voices. I think for too long, sepsis has fallen in the domain of critical care. And it often occurs to me, by the time they get there, it's kind of too late. And you get into this bottleneck of pathophysiological pathways that are closer to death than they are to the host trying to make themselves better. And that we need to diversify where we're doing these studies. And I think Azra touched upon it too. My thing is, how much of this is actually preventable? And I, really want to focus going into the future. And to Andre's point, we need to collect data that we don't know we need, and we need to collect it indiscriminately. And I think it is happening more and more. So another plug for our APS consortium, which is sponsored by the NHLBI and NIGMS, where we are actually collecting multidimensional clinical and biological data, and that resource is available for everybody. So please reach out and tap into that for your research programs.
It's important for us also, like that's a very good point about diversifying the settings. I mean, I'm a pediatric ER doc, and we need to utilize the emergency room. That's where the patient shows up, before they get to the ICU or to the floor. So there's a lot to be done there. Unfortunately, one of the major problems, and I'm going back to the definitions, is that the definitions are mostly for the ICU, because even sepsis 3, we don't have all the data in the first hour or two in the emergency room. So that becomes a huge problem.
Yeah, excellent points. I mean, Pratik, I like to use a slide where I say the ICU is an exit wound. Like you could patch up an exit wound, but by the time you're there, like you can only, it's a byproduct of a bullet that's gone through and created its own kind of whatever, trajectory. We have to get to the projectile itself and to the, to the gun or whatever, and so we do need to include those voices. Absolutely. It looks like Nitin, you had a question.
Yes, so this is a very intriguing discussion, especially what Pratik said recently, that he still kind of strives to understand what sepsis is. And I want to, and you did shared some thoughts about why you think so. But my question was that and this question is for everybody here in the panel or in the whole meeting, that if you have to define certain parameters that should be the pathway to identify sepsis, then what would they be? Because right now we have identified a critical gap in the knowledge, basically, that that it's not well defined what means what sepsis means at the end. So how should it be defined in your view?
I have to leave, I'm afraid. I can't answer that question. It's too hard. It's okay. Again, I'm just going to give a very short answer. I think that there are practical utilities of how we've been doing sepsis so far, right? I think it has focused the mind towards early antibiotics, resuscitation of patients who are demonstrating early signs of organ failure. But beyond that, it is really, really difficult to find features that would exist in this ideal model, because infectious responses are so varied, they are so dynamic, that I think we need to start from the beginning, and we need to collect data and understand exactly what it is and what are the factors that drive the host response. And we have some very early data that suggests actually, even in bacterial infections, the pathogen-specific response of the host is quite different. And these are sort of foundational principles that we have not got at. So I think even before we can get to these features that could unify this sort of disease state, we need to better define what it is, what drives it.
Yeah, I just want to say we spent an endless amount of time trying to figure out what our electronic definition would be, recognizing that all of them would be imperfect. And I feel like there's a reliance on our, immunologic colleagues doing basic science research to actually figure out what the pathophysiology is and come up with a test that we can then build out clinically and incorporate into our models. But until that exists, we're using all of these rough clinical parameters. And I think, I like to use the analogy, I don't know if you guys have heard that quote from the Supreme Court, that they didn't know what pornography was. They know it when they see it. And I feel the same way as a clinician. It's like, I can't define sepsis, but I know it when I see it. But how do you actually make that a predictable outcome? Obviously the clinician gestalt is just impossible to capture in structured data, which is why I do think there's a lot of opportunity in this unstructured data, but it's still not the key pathophysiology of what's going wrong with the immune response that we need our basic science researchers to answer for us.
And maybe just expand, if you don't mind, Kara, is the way how I also think about this, as a mental model, is that for me, sepsis is just another manifestation of, aging human body in contact with the environment. Like we are constantly battling the world. And, the infection is just one thing that can kill us. There is injury, there is trauma, there is all kind of stuff, surgery, cancer. But it is, a very holistic process. I always say it's a control system problem. It's a problem with the control. So it affects every single organ. We call it homeostasis. We still don't understand completely how that happens, how we age, and getting deeper understanding of human health would help us also define all of these very complex processes that happens with the aging. That's why you see comorbidities, elderly, perioperative. When you add additional insults, it becomes really harder. And I think, as much as I want us to be outside of the work, I would say we can probably learn how to take care of a lot of these things so they never happen. But there will be always very older people and very big insults that we will have to deal with. And at that point, we need to understand what does it mean to control human body, like what and how do we recover for some kind of deadly injury. And I think that time will come. Is it regeneration or I don't know what, but it will come, not maybe in my lifetime, but I hope it is, maybe because I plan to live 150 years, so we will see.
I think part of it also is, number one, there's this disconnect between the data clinicians have access to and what we potentially could be testing, right? So a lot of that isn't at the bedside. I think if we get to that point where we can have a lot of that data available to us, maybe it might be easier for us to identify exactly what sepsis is. The other data that we're missing, to Asra's point before, is that I have no idea at what stage this patient is coming to me in their sepsis, right? So patients that I see in my hospital, for instance, tend to come pretty late when they've already exhibited lots of signs of organ dysfunction. But there are patients in other hospitals who may come very early in their clinical course. And those two disease states at that particular time may be very different in terms of their host response. So I can't really quantify exactly what that looks like without knowing what their baseline data is. So access to that kind of data would, I think, also inform how we can define sepsis in the future.
Yeah, I think of I read a book about hurricanes and the technology they used over time to, improve our forecasting and not treatment, but, whatever they could do to, minimize the byproducts of that. And, I think our organ dysfunction measures currently are somewhere in like the wind speed, measure classification, but they're very incomplete. And, I think a lot of that history started with the modeling approaches, with this kind of concept of the butterfly effect, that there's a lot of randomness in the trajectories that can start from a very initial stage, like Ezra has described. We're constantly being insulted. For some reason, at times we can put that down, and at other times it becomes this raging, hurricane. But then instrumenting that process over time, they used to fly airplanes really close or in, and now they have all these sensors which they can deploy actually directly into that to that hurricane. So but the taxonomy of it all was very, very important to drive kind of the understanding of how to mitigate the byproducts. It looks like we had some other hands. Let's start with Dr. Liao, because the others have retracted their hands for now.
Hi, I was just wondering, in the US, is there a network for sepsis? I'm just thinking in Canada, we have Sepsis Canada, which is a research network made up of researchers, healthcare providers, and patient partners. And we have several goals that range from basic research to population studies. I'm just wondering, is that something that's also present in the US?
There are multiple networks from what I can talk about pediatric networks, the Society for Critical Care Medicine, the PCARN, which is actually an association of emergency departments across the US. And there's a critical care, severe illness and trauma subgroup that works on sepsis. So there are multiple different organizations and consortia that work on sepsis in the US. Again, I know more about the pediatric world, but many of you know about the adult world as well.
Okay, thank you.
I saw Prithu as well as Guofei with your hands up before. Did you want to come back on and ask your question?
I think I had a very layman's question actually. So I am assuming that most hospitals have the data for patients who died of sepsis, which were severe sepsis, and I'm sure their EMR data is also exists. Is it possible, or maybe you already have touched that these AI algorithms, you can train them for all those patients and based on their EMR data to predict at least mortality or severity of sepsis rather than different stages of treatment that some patients, whether it's a trajectory towards mortality or not?
So,
yeah, go ahead, Andre. No, you.
No, I was just going to say, so there, as a matter of fact, in the earlier stages of this research, there were a lot of models that predicted mortality in patients with sepsis. The problem with the predicting mortality is, as a clinician, I have no idea what to do with that information, right? So, what is the actionable thing that I can do that can prevent that from happening? And so, that's partly why we, a lot of the work that's happened since then is to help identify things that we can actually find something that outcome is associated with, and link it back to something that I can do to correct it.
Great. And Guofei, final question?
Sure. Thank you, Vinny. Regarding the different voices you guys touching upon, so you guys wanted the multiplicity of data in the sample and biomarkers. Now, I did not hear you guys touching upon the patient angle, how patient thinks and how does patient perspective contributing to what the AI models you guys build upon. So reason why I'm asking this is we are dealing with patients who are critical ill. For example, the APS consortium Pratik mentioned, we collect a lot of data in the biosamples, but these patients are under a lot of distress. The consent rate is not really great. So I'm thinking if we needed to listen to patient, what is the minimal data elements or the sample elements you would like to have? That way it'll help us as researchers to be able to answer the scientific questions. Meanwhile, we can mitigate the stress our process can impose on the patient. Over. Thank you.
Maybe there's a question for Azra. Because you want everybody to instrument themselves, right? Quantified self, collecting their samples and rings and helmets with neurologic signal. I mean, I think the patients are critical because I think there's a big education gap in terms of the incipient symptoms and circumstances that lead to infection as a precursor to dysregulated immune response and risk of mortality. I think the tool sets do exist to instrument have patients instrumenting so that we could understand those factors. And they're going to be critical partners to do that, because I don't think it's feasible for us it would be very challenging to do this at scale without patients buying into that process and actively being, understanding the rationale for wanting to link up these data with what we only observe, downstream or only in partial ways. So I think we do need to do a better job in that domain. I think it's a challenging area.
And along those lines, for Dr. Bihorik, that she talked about the digital twin, I really like that idea. It is also very important. Maybe we need to focus more on precision medicine, and instead of trying to tackle this as having one definition, one approach. Maybe this heterogeneity is so hard to overcome that we need to focus more on each patient individually.
Yeah, so instead of one color, we see entire spectrum, right? And that is hard for human because we tend to think more reductionist. But I think that's where I've seen technology can help us, right? I always think that we can get a superpower with AI technology because it helps us bring that complexity into human way of thinking. That is, again, what we want. So I would just add on what Vinny said. I think patient needs to be empowered to understand that there is no better doctor than yourself. like you are your best helper. Like that understanding, the deep understanding how much control we have as a humans, and how much simple things like what we eat, like how we feel and how we connect influence our health. That is absolutely critical. So I'm a nephrologist and intensivist, and more I think about it, I go back to like primary care, like really prevention is the key, and education about importance of prevention and importance of these tools that maybe one day it's not going to be hospitals who can on the cell phone tell you, you're not doing well, go to doctor or something like that. That is going to be at the tip of the hand. And our job is to educate our patient and think about that.
Great, wonderful. Well, thank you all for just a tour of what the opportunities are for AI in sepsis. And I think it's really, really intriguing to see what these next 5 or 10 years will bring in terms of precision medicine and in terms of our understanding of the full kind of spectrum of sepsis, from communities all the way down to proteins. So thank you again for that. And with that, I'll turn it over back to Nitin.
All right, thank you, Vinny. And first of all, I would like to congratulate all the speakers here and all the chairs for keeping the track of time so much. We are only 5 minutes behind in the entire day meeting, which is amazing. So thank you all again for keeping this on track. Let's take a quick 10-minute break, and we can reconvene at 4:15. And after that, we will have the concluding remarks from the chairs and moderators for each session, and that will be the end of the meeting after that.
Recording stopped.